Okay, excellent. Well, good morning and good afternoon to our participants today. My name is Rob Baiocchi. I'm a professor at The Ohio State University in the Division of Hematology. And I've been working with the Global One Health for close to 8 years now. And over the past several years, we've held a Summer Institute internal medicine series where we've reviewed various topics in general medicine, internal medicine, infectious disease, cancer, and today is the first day of our hematology oncology session, where we have various topics in solid and blood cancers. So each speaker will have about a 40-minute presentation. Then we have about 5 minutes or so after, where you can ask questions. You can also put questions in the chat during the talk, so we look forward to a great day today. Our first speaker is Dr. Shafia Rahman. She's an assistant professor at Ohio State and focuses on treating patients with gastrointestinal malignancies such as pancreatic cancer, colorectal, hepatobiliary, and gastroesophageal malignancies. She's going to kick off our HemOnc part of the conference with an update on the management of pancreatic cancer. And I'm going to go ahead and allow her to share her screen. Thank you for joining us today, Dr. Rahman.
Thank you so much for having me. Trying to share my screen. Can you see my screen?
Yes.
Okay. Okay, well, good afternoon, everyone. Thank you for this opportunity. I'm an assistant professor in the Division of Medical Oncology at the James Cancer Center at Ohio State University. And I'll be talking about updates on the management of pancreatic ductal adenocarcinoma. I have no conflicts of interest to disclose. The agenda of my talk is basically divided in 3 sections. We'll talk about the introduction of pancreatic cancer, staging and management, and novel therapies. So how common is pancreatic ductal adenocarcinoma, mostly known as PDAC? So we know that PDAC is one of the aggressive malignancies. We know, and it leads to almost 3% of all new cancer diagnoses, and is also associated with a higher mortality, which accounts for 7% of all cancer-related deaths within the United States. In terms of the global burden, based on the statistics from 2022 from Globocon, it is the 12th most common cancer in terms of incidence and ranks 6th in terms of mortality. So based on the region-specific incidence age standardized by sex, here we see the burden of the pancreatic cancer throughout the globe. And in East Africa, it's almost 1.9 cases per 100,000 males and 1.6 cases per 100,000 females. So the peak incidence we see around age 60 to 70 years. Mostly the male-female preponderance is similar. And adding to this insult of increasing incidence of PDAC, especially in the West, it is going to be the second leading cause of cancer-related death by the end of 2030 in the United States. Despite being not the most common malignancy, as I showed in the previous slide, involving only the 3% of new cancer diagnoses, it has a dismal overall survival, and that accounts to basically the stage of presentation of this disease. So here this cartoon shows that the 2/3 of this disease is, at the time of diagnosis, it's either metastasized to distant sites in the body, or it's already locally advanced. And as we know, surgery is the only chance of cure in pancreatic cancer. So 2/3 of these patients who are diagnosed with pancreatic cancer, they are not able to go to surgery. And that is the main reason that we have the overall survival is poor in this disease. As I said, regional is around a combination of distant metastatic disease plus locally advanced, which you can also call as regional disease, is accounts for almost 2/3 of the new cases. And the overall 5-year overall survival is less than 10%. And in terms of distant metastatic disease, it's less than 3%. I'm not sure if it's going to be an interactive webinar or not. I try to keep it to see if there's any, making sure that this remains an active learning session. So here are the various mutations, and you can answer in the chat. Which of the following hereditary mutations is associated with the highest risk of developing PDAC? Okay. The highest risk of developing PDAC is basically associated with STK11. It's a tumor suppressor gene, and if it is mutated, it's an acquired autosomal dominant. If it is autosomal dominant mutation, and if this happens, it leads to increase in the risk of pancreatic ductal adenocarcinoma, and the risk is increased by almost 100-folds. So the risk factors associated with pancreatic ductal adenocarcinoma, there are some modifiable risk factors and some are non-modifiable. The most common modifiable risk factors are smoking, obesity, diabetes. There is a heavy alcohol intake, chronic pancreatitis, and family history. If there are 3 or more first-degree relatives who have had pancreatic cancer, and then it increases the risk by 20%. And so the 3 main risk factors you can remember: smoking, diabetes, which goes in hand with obesity, and genetics. And then here are these hereditary syndromes. Although we see BRCA mutations, they are one of the most common mutations we see in familial pancreatic cancer, but they're not the only one. So here's a list of mutations which we can see are associated with pancreatic ductal adenocarcinoma. And as I mentioned earlier, STK11 is associated with 100 times increased risk in developing PDAC. The common mutations within the pancreatic ductal adenocarcinoma. So KRAS is one of the most commonly mutated oncogene, and this is one of the main reasons also that the current systemic chemotherapy options which we have available are not able to give us a long-term effect on the disease, because this gene so far, it has been non-druggable for quite a long time. Recently, over the last few years, we do have some direct therapy for KRAS G12C, but the incidence of KRAS G12C is less than 1% in pancreatic cancer. So overall, in pancreatic cancer, we don't have a drug which is approved at this time as a KRAS-directed therapy. Other genes which are alterated is TP53, that is the guardian of the genome. It's associated, and that leads, that in itself, when it is altered, leads to an aggressive cancer. These are the other list of the genes. This slide will come out later in this talk when we talk about novel therapies and other mutations in PDAC. So in terms of presentation, how does pancreatic cancer presents? The symptoms are vague, and in some patients, they may not even have symptoms until they have metastatic disease. So most common symptoms there is abdominal pain. It can be weight loss, painless jaundice, and sometimes patients may have upper GI symptoms, other like nausea, vomiting, change in bowel habits can be there. New onset diabetes in an elderly patient, or if somebody previously had a very well-controlled diabetes and now all of a sudden and their diabetes is out of control despite doing all measures in terms of therapeutics, and it's still not getting, the blood sugars are still not getting controlled. It should raise a suspicion about pancreatic cancer. I basically had a patient. She was a professor at a nursing school, and she was diabetic for many years and was very up to date on her medications, on various preventive measures and everything. And all of a sudden her diabetes started to act out, and her blood sugars were very brittle. And she finally basically advocated for herself and asked her PCP for a CAT scan of her abdomen. And on that CAT scan, a pancreatic mass was noted. Thank God at that time it was still at early stage, and she basically had a neoadjuvant. We gave her neoadjuvant chemo followed by a Whipple resection, and she is still following up with us, and she has been cancer free. So that is one example about a brittle control of previously well controlled diabetes, or in elderly patients who are developing new onset diabetes. Serum markers, they are not used for screening, but when we are suspicious about pancreatic cancer, we do check the serum markers. And they also help in prognosis, and also help in determining the treatment assessment. Then there are precursor lesions which give rise to pancreatic ductal adenocarcinoma, and the most important common of them is pancreatic intraepithelial neoplasia, and then others are like IPMN. And so IPMN is the one which you might have incidentally seen on CAT scans and should be followed based on their size. If they fit the size criteria, then they should be evaluated with an ERCP. Then location. So majority of the cases, they arise basically from the head and the head and neck of the pancreas, so head and the uncinate process. So that accounts for 2/3 of the cases, and less than 1/3 of the cases, they arise from the body and the tail. Again, this this has inference on the management, because as these lesions arise from the head and the uncinate process, they are in close proximity to the vital structures over there. So like the blood vessels, the vascular structures which are in that area. Then in terms of histology, so as you might have noticed, I have been talking mostly about pancreatic ductal adenocarcinoma. So adenocarcinoma, it's the majority of the histological subtype we see, but there are other subtypes which I have listed here, which can be seen in pancreatic cancer. Overall, they all are treated the same way as we treat adenocarcinoma, but then just keeping in mind there are other histologies as well, which can be seen in this cancer. So how do we approach a pancreatic ductal adenocarcinoma? Based on the NCCN guidelines, which are followed in the United States, so whenever there is a suspicion of a pancreatic cancer based on the initial imaging, it has to be referred to a multidisciplinary team, where not only the imaging, but we also discuss resectability. So here at James, for example, we have a pancreatic multidisciplinary clinic, and in that clinic, we basically see all new cases of pancreatic cancer. They get imaging, which is a pancreatic protocol CAT scan, the same day when they come to us. And after that, we discuss their case in a multidisciplinary conference, and then they are seen by surgical oncologists or medical oncologists, and if they need to see radiation oncology, they also meet with them. So you really need a multidisciplinary team for these cases, because determining the resectability is the key for management. So the initial workup, so for first, it starts with any clinical suspicion, which can be either, as I mentioned earlier, abdominal pain, painless jaundice. So initial imaging is needed, and pancreatic protocol CAT scan, which is a CAT scan with thin cut slices, almost 3 mm slices, or an MRI abdomen, is the initial study which we need to determine the resectability. And once we have that, the cases are should be discussed on the multidisciplinary tumor board, at least involving the surgical oncologist, medical oncologist, the radiologist, and the radiation oncologist. So then we determine whether the metastatic disease is present or not. So getting staging CAT scans. And after that, if the staging CAT scans do not show any metastatic disease, then you go for EUS and to get to basically have a tissue diagnosis. And that not only confirms but it can also be therapeutic. For example, if patients are having painless jaundice, then you can combine the EUS with ERCP, and they will benefit from a stent placement. You also check the baseline labs, which not only include the CBC, but also like the liver function test, and you also look for their baseline CA19-9. And then after that, however, if there is metastatic disease at the presentation, then patients we don't need to go for an aggressive test like an EUS. We can just biopsy one of the metastatic sites. And then based on the location of the mass and its relation to the vascular structures, the resectability is determined. Apart from that, all patients with pancreatic cancer, they should have genetic testing, and they should have tumor profiling. Especially the tumor profiling is important in the ones who have metastatic disease or locally advanced disease. PET scans are usually not done in pancreatic cancer patients at the beginning, at the diagnosis. However, if we do not see any metastatic disease on the CAT scans, but patients have high CA19-9, which doesn't correlate, because high CA19-9 we know correlates to higher disease burden. So if that is, we don't see any metastatic disease, we can do a PET scan. Another one, well, if patients are having a lot more symptoms, they are more symptomatic, and we can get more information by doing a PET scan. So here are the reasons I have listed for getting a PET scan. So in terms of staging, this is I'm not going to spend too much time on this slide. This is a TNM staging. You will see based on the management is basically not based on TNM staging. It's more based on the clinical staging, but we do have TNM staging, and where we look for the T size and lymph node involvement and distant mets. This is a normal CAT scan, I should say, or the CAT scan showing the location of the pancreas and where exactly the structures which we are looking at. So if you know there's the pancreas, and then we're looking at SMV, SMA, and inferior vena cava. There's also like portal vein, and not in this slide over here, but portal vein and common hepatic artery, they are also in the same region around this pancreas. So why is it important? Because it determines the resectability. So resectability is defined if there is no arterial involvement, meaning the tumor is not in contact with any artery like SMA, celiac axis, or common hepatic artery. It is called resectable. In terms of venous involvement, as you saw, there was an SMV there, or a portal vein. So if the tumor is not in contact with them, or the contact is less than 180 degrees without changes in the vein contour, it is determined as resectable. Now coming to borderline, there is some involvement of the vascular structure. If the arteries are of the contact with arteries is less than 180 degrees, and the veins, it can be more than 180 degree. However, if it is less than, however, there should not be any thrombosis in the vein, or if the solid tumor contact with IVC, it should also be less than 180 degree. So for locally advanced, whenever the solid tumor contact or the mass is in proximity with the blood vessels, it's more than 180 degrees, like SMA or celiac axis, then it is determined as locally advanced. So you can say unresectable. So then, that is this determines the resectability. It determines the overall prognosis, and because if you in this table, as you see, on just the resectable disease and borderline resectable are actually the cases which can be taken to surgery. Locally advanced cases, majority of them are not amenable for resection. We give them neoadjuvant chemo, and a portion of those patients can attain resectability. So identifying the vascular involvement, again, I thought this could be an interactive session. So as you see in the first image, there's a tumor there, and then the SMV and SMA. And if you look through image 1, image 2, and image 3, you see the involvement. So in the first image, we see the tumor. It's not completely enclosing around the SMV, SMA, and SMA. There is some involvement, but less than 180 degrees. So this is actually borderline resectable disease. And if you look at the second image, we see the tumor. SMA is not at all involved, and SMV there is and there's less than 180-degree involvement, and based on the imaging, we don't see any changes in the vein contour. This is an example of resectable disease. And here you see in this CAT scan, you see the pancreatic mass, and there's almost complete encasement of the SMA. And even it's very, so we cannot really, so this mass is technically not resectable. So this is an example of locally advanced disease. So based on the management is basically based then on the combination of the staging, so resectable, borderline resectable, locally advanced metastatic disease. So surgical resection, the goal of the surgical resection is basically to attain an R0 resection, taking out the primary and the regional lymph nodes. And to a pancreatic protocol, CAT scan is very important to have that preoperative assessment and planning. So if it is involving the head and the unsnake process, you see patients undergo pancreatic endarterectomy, which is a Whipple procedure. However, if it is involving the tail and the body and the tail, they go a distal pancreatectomy. And based on the path, the margins are considered positive if they're present, if the tumor is present at the margin, or it's within 1 mm of the resected margin. In terms of resectable PDAC, so resectable PDAC, it forms a small portion of the newly diagnosed cases. So the standard of care is actually surgical resection, and after surgical resection, adjuvant chemotherapy has to be given. In many of the centers in North America, we basically do neoadjuvant chemo in the resectable pancreatic cancer as well, followed by resection. There are currently clinical trials going on to see the benefit of neoadjuvant chemo versus upfront resection. So in terms of resectability, there have been various trials which were done. Initially, a trial with single agent gemcitabine was done, looked at gemcitabine versus placebo. Patients who received gem in adjuvant setting, they did better. Then they added CAPE to the gemcitabine, and it was noted that gem CAPE was better than gem alone. Then modified FOLFIRINOX versus gemcitabine. Again, modified FOLFIRINOX was noted to be better than gemcitabine. And then GemNab was compared with single agent gem. So that was also noted to be better than single agent gemcitabine. We do not do radiation in resectable setting. However, it can be given if the margins are positive, so radiation could be offered in those patients. So this is the SPAC4 trial, basically adjuvant gemcitabine plus Xeloda or capecitabine in resectable pancreatic cancer. So here you see that the overall hazard ratio of 0.82. The overall survival was better in patients who received a doublet of gemcitabine plus Xeloda. Then second, this is the PRODIGE trial, which basically compared adjuvant modified FOLFIRINOX with single agent gemcitabine. Again, we noted improvement in the overall survival, so hazard ratio of 0.58. This was the APAC trial, which basically showed adjuvant gem-nab-paclitaxel versus gemcitabine alone. Again, increased improvement in overall survival was noted. This table basically summarized these are these are three main trials in the adjuvant setting. So SPAC, PRODIGE, APAC. What I would like to point out here is overall what we have seen that over a period of years, the overall survival with even just the single agent gemcitabine has improved from 25 months to 37 months. So basically pointing towards a better patient selection for adjuvant therapy. This is the PREOPANC trial in which neoadjuvant chemotherapy versus upfront resection was in patients with resectable and borderline resectable disease. So basically, patients were randomized to either GEM followed by GEM-RT versus resection versus upfront resection. And the primary endpoint was overall survival, and the secondary endpoints were resection and the R0 resection rate. So what we see here, that patients who received GEM plus radiation, they did better than as compared to those who went for upfront surgery. So radiation therapy overall there are a few scenarios where we involve radiation therapy. Resectable, borderline resectable, I would say more for borderline resectable cases. For resectable cases, we usually offer it in adjuvant setting if there was any margin positive disease. Again, as I mentioned here, in adjuvant setting, locally advanced cases, as I will mention, there has been a clinical trial which has shown in locally advanced cases, if you offer radiation, that increases the rate of R0 resection. In palliative settings, it can be used to relieve the cancer-related pain, and in recurrent disease, radiation has also been used. So, as I was mentioning, for locally advanced or borderline resectable cases, to sterilize the vessel margins, meaning taking the cancer mass away from the vessels, and then providing local control and also helping with pain control. And this was a SWOG 1505 trial. So basically in this trial, patients with resectable pancreatic cancer, they were randomized to receive modified FOLFIRINOX versus Gemna paclitaxel. And the goal of the trial was to basically to pick a winner, which neoadjuvant chemo regimen is better. And their specific goal was OS rate of more than 558%. This trial, however, failed to achieve its primary objective. But what this trial showed was actually these both chemotherapy lines are efficacious. So basically, initially, there was some bias that maybe triplet is better than a doublet, but overall, this trial showed that in resectable, borderline resectable settings, it's more of the performance status of the patients what matters in terms of which chemotherapy they can get rather than triplet or doublet, because both this trial showed that both these chemotherapy options are effective. The NORPAC trial. So this trial was presented last year at annual ASCO meeting. So this was done in Scandinavian nations. So what they did, they took patients with resectable disease and they randomized them to surgery versus upfront chemo. They used 4 cycles of neoadjuvant FOLFIRINOX followed by surgery, followed by adjuvant FOLFIRINOX up to 12 cycles. And in the upfront surgery, they were supposed to receive 12 cycles of adjuvant chemo. Both these groups were balanced in terms of their demographics. So what this trial basically showed that in the overall survival was was inferior, I should say, in both intention to treat or per protocol patients. Those who received upfront resection, they had a better overall survival as compared to those who received neoadjuvant chemo. As you see here, 25 months versus 38.5 months. In terms of adverse reactions, and this was fairly well tolerated. Obviously, with the triplet, we do see a little bit more of overall more adverse reactions in terms of diarrhea or neutropenia. However, there are some nuances with this trial. So only half of the patients they received the originally assigned neoadjuvant arm. They received 4 cycles, and 4 cycles of modified FOLFIRINOX is, as we see clinically, it's not a whole lot of chemo. It will be 2 months of chemo, and we see majority of the patients are able to tolerate. So we're not sure why only half of the patients were able to receive the treatment in the neoadjuvant setting. Second, in the patients who got neoadjuvant therapy, they had a higher R0 resection rates, and they also had higher node negative disease, and which should logically lead to a better overall survival. As we know, if the path there's R0 resection and node negative disease, it's a good prognostic factor. However, in this trial, despite having higher R0 resection rates and node negative disease, these patients seem to have a worse overall survival, which we are not sure why that has happened. So that has a potential flaw of this trial. It needs more data before we can really implement this. And only a majority of the patients received FOLFIRINOX. So on this trial, they were initially in the adjuvant setting, gemcitabine was supposed to be the adjuvant setting. Some amendments were made. So there are some potential flaws in this trial. There's a alliance trial going on right now, which will basically answer this question, whether upfront resection is will be helpful in patients with resectable pancreatic ductal adenocarcinoma. Hopefully, this trial will be completed in the next couple of years, and we may this question we may have some answers for this question, whether resection, upfront resection is beneficial versus neoadjuvant chemo should be given to resectable patients. Then neoadjuvant therapy in borderline resectable cases. So borderline resectable cases, again, we try to take care of the micrometastatic disease. If the vascular margin needs to be, if we like the tumor to shrink a little bit, to come away from the vascular structure. So that's the main reason giving borderline resectable disease to give neoadjuvant chemo. So we can use modified FOLFIRINOX or Gem/nab-paclitaxel, and in patients who have a BRCA mutation or PALB2 mutation, which is the reason that all patients with pancreatic cancer who are diagnosed with PDAC, they should have germline testing. Because if they have BRCA mutation or PALB2 mutation, we know that these mutations, they respond more to platinum-based regimens. So modified FOLFIRINOX or GemCis are the regimens of choice. This is Alliance AO21501. So in this neoadjuvant modified FOLFIRINOX was basically used with or without radiation. So patients were basically randomized to FOLFIRINOX, and then they were taken to surgery versus FOLFIRINOX, and then had radiation, then taken to surgery. So the primary endpoint was overall survival in 18 months. So what this trial showed that overall, the patients who basically got radiation, they had their overall survival was inferior as compared to those who didn't receive radiation. This was another, so again, we do have some conflicting data about radiation. And on this trial, 007 study, so basically patients with locally advanced disease who were unresectable, they had induction chemo, and they were randomized to induction. After induction chemo, receive radiation. And what this trial, and the primary endpoint was R0 resection, to see by giving chemotherapy followed by chemoradiation if we are taking these patients to resection or not. So what this trial showed that yes, there were higher PCR rates, meaning pathological CR in patients who underwent radiation, chemoradiation. Second, the R0 resection rates, if you see here, were higher in patients who underwent chemoradiation. And so overall in terms of overall survival, we didn't see an improvement in the overall survival. So again, this is this table tells us about the resection rate, the difference which we noted in patients who received chemo-RT in addition to neoadjuvant chemo. So more number of patients went to resection. As I mentioned before, I'm going to skip this slide. Then coming to metastatic PDAC. So the overall survival is dismal, and performance status is linked to survival. So patients who have a lower performance status, they actually do worse. And for patients with a good performance status 0 to 1, we try to trials have shown advantage with giving modified like a triplet versus a doublet. So triplets have shown a better efficacy and better overall survival in patients with patient metastatic PDAC. For patients who have poor PS, then Gem/nab is reserved for those patients. So the key trials which were done in this setting was the PRODIGE trial and MPACT trial. So PRODIGE basically modified, now the FOLFIRINOX was compared with single agent gemcitabine, and the MPACT trial, Gem/nab, was compared with gemcitabine. So both these trials show that single agent gem was inferior to doublet and triplet regimens. Here, this table basically shows the demographics and overall results from these trials. So we do see that the overall response rate and the median PFS was higher as in a doublet or triplet as compared to single agent gemcitabine. Now, is there going to be a trial which will compare modified FOLFIRINOX with Gem/nab-paclitaxel? Probably not. What we know now, especially after the Napoli 3 trial, that triplet is better than doublet if patients have good performance status. So again, as you see in these Kaplan-Meier curves, the overall survival was better in PRODIGE with FOLFIRINOX, I should say, and in Gem/nab-paclitaxel. In the impact on trial, Gem/nab-paclitaxel had a better survival than single-agent Gem. So this safety data with the triplet, we do see overall more side effects like neutropenias and thrombocytopenia, and overall more peripheral neuropathy. So this was the NAPOLI-3 trial. This was presented last year at ASCO in GI, and then had an updated annual ASCO. So basically in this trial, and they used modified irinotecan, which is basically liposomal irinotecan with 5-FU and oxaliplatin in patients with metastatic treatment-naive pancreatic ductal adenocarcinoma. So basically what it is, we know that one of the major factors or reasons pancreatic ductal adenocarcinoma is an aggressive disease is because the chemotherapy is not able to penetrate in the cancer cells, and that is because of the tumor microenvironment, or that's because of the stroma around these cancer cells. In the liposomal irinotecan, it is formulated in liposomes so that it's a better delivery mechanism. It has a topoisomerase 1, a better delivery mechanism to enter, to go through that stroma and reach the cancer cells. And this trial was basically, NAPOLI-3 trial was done based initially on the previous data, which is liposomal irinotecan plus 5-FU, which is currently approved in second-line setting. So in this trial, metastatic PDAC, not treatment naive patients, they were basically randomized to nalarifox, which is liposomal irinotecan, 5-FU, leucovorin oxaliplatin versus Gem/nab-paclitaxel. And the primary endpoint was overall survival, and secondary endpoint was PFS and ORR rates. So these are the baseline characteristics. As we see, patients are well balanced in both groups. Again, the head and the main pancreatic location you see here. The liver mets are the majority of the cases, because as we know, liver is the most common site of mets in pancreatic ductal adenocarcinoma. So patients are overall well balanced in both the arms. So in terms of primary endpoint, both in intention to treat and in the subgroups, we saw that nalarifox did better, and then Gem/nab-paclitaxel. And the secondary endpoints, the PFS, and also in the subgroup analysis, we see that nalarifox did better than Gem/nab-paclitaxel with an hazard ratio of 0.69. In case of tumor response, majority of the patients had a partial response or stable disease, and objective response rate was also higher in the nalarifox arm. And the side effects, we know with the liposomal irinotecan, we can see more neutropenia. We can also see more diarrhea as compared to Gem/nab-paclitaxel. So again, they were updated efficacy results presented at ASCO annual meeting last year. Again, nalarifox continued to show higher efficacy. Then in terms of cost effectiveness, so this is one major factor here that we know that in liposomal irinotecan costs much higher as compared to regular irinotecan. As you see overall here, it is regular irinotecan is around less than $50, but liposomal irinotecan is around $5,000. So that is a significant financial toxicity to our patients. So we do based on the NAPOLI-3 trial, there are some instances where you can favor nalarifox versus modified FOLFIRINOX. So if, for example, patients have underlying neuropathy, so you can use nalarifox because the oxaliplatin dose is less as compared to FOLFIRINOX. Or if the patients have more diarrhea from the pancreatic insufficiency from underlying pancreatic cancer, then modified FOLFIRINOX will be preferred because liposomal irinotecan can give them more diarrhea. Irrespective of the fact, this trial basically again solidified that triplet is better than doublet if patients have good performance status. So maintenance, so once we give 4 to 6 months of treatment of a triplet or a doublet, after that we should move to maintenance therapy because again, this is an aggressive cancer, and keeping on treating patients with a triplet is not ideal. They will develop a lot of toxicity and side effects from these regimens. So moving towards maintenance once you have achieved stability is the usual clinical practice. So potential maintenance from FOLFIRINOX could be FOLFIRI or capecitabine, and for GemNab could be modified GemNab scheduling, meaning doing every 2 weeks, or doing gemcitabine monotherapy. So Napoli trial, as I mentioned earlier, this is in second line setting, and here it showed that liposomal irinotecan plus 5-FU. And they did patients who received this had a better overall survival. I'm going to skip this. So overall choice of first-line chemotherapy regimen based on age and performance status. If your patients are younger and they have a better performance status, choosing a triplet, FOLFIRINOX and NALIRIFOX. GemNab has basically now moved to ECOG-2, and even single-agent Gem could be given to ECOG-2 if they are not able to receive a doublet, or if they have neuropathy and they cannot get the nab-paclitaxel. Then supportive care is reasonable option in some patients who are not a chemotherapy candidate, meaning ECOG more than 2. And in patients who are more than 80 years of age, triplet, we usually don't use triplet in them, given the side effects associated. So GemNab or single-agent Gem is the go-to regimen. And if they don't have a good performance status, doing supportive care is reasonable. So in terms of sequencing, so again, it depends on what the performance status is at the time of presentation, and how old are they. So doing a triplet, if you're doing a triplet, then switching to GemNab in second line. If you're starting with GemNab, switching to liposomal irinotecan and 5-FU in second line setting. Then KRAS mutation, as I mentioned earlier, KRAS mutation is one of the common mutations in pancreatic cancer. So it is present in 90% of patients, 90% of cases in patients with PDAC, and in 10% of the patients who are wild type for KRAS, they will have one of the mutations which can be targeted. So that is another reason for patients with metastatic disease and locally advanced disease, please get the sequencing of the tumor done, because if they are wild type, which is 10% of the cases, they may have a targetable mutation, and right now we have drugs approved for these mutations. So we always need to look for these patients. So and that's the main reason doing a genetic as well as somatic sequencing of the tumor is very important. Here we see that KRAS G12C, for which right now we have an approved drug, but that comprises only less than 1% of the cases. In the majority of the cases, majority of the KRAS mutations, we don't have a approved drug at this point, but pan-KRAS inhibitors, they are in clinical trial setting. So again, KRAS, it acts as an on-off switch. If it's off, the cell cycle is not progressing. If it is on, we see that brakes are taken off, and it leads to cell proliferation. Here, sotorasib and adagrasib, they are the two KRAS G12C inhibitors, which are right now approved in clinical setting based on Crystal-1 and CodeBreak 100. Again, here in the CodeBreak 100 trial, there were patients of PDAC, and almost all patients either had stable disease or they had a partial response. As you see in the waterfall plot here, majority of these patients, they responded very well, and disease control was 84%. Disease control rate was almost 84%. This again, the Crystal study, it was a basket trial, and again in the solid tumor group, we saw the GI tumors responded well. For pancreatic cancer, again, we see the response rate was 50%. 50% had stable disease, and so the overall disease control rate was 100%, which is actually astonishing given the aggressive nature of this disease. This was a newer agent which was presented at ASCO GI. Then the KRAS vaccine. So this is something new which is upcoming. So basically patients who underwent resection, they're based on their resection tissue, a vaccine was developed, which was precision, more of a precision oncology, meaning vaccine directed to each patient. So if they had MRD, meaning minimal residual disease, even after resection, and then they were given the vaccine. And what we noted that with the KRAS directed vaccine, the minimal residual disease was cleared in majority of the patients. So this trial is ongoing, and the initial results were presented at the annual ASCO meeting. Then there was adjuvant mRNA vaccine. You might have heard about this trial going on at MSK. So basically, what was done in the proof of concept study at phase 1, patients were taken who had resectable disease. They underwent resection, and after that, based on their resectable tissue, their tumor was sequenced, and an mRNA vaccine was created. And after that, this mRNA vaccine was injected back into the patients. They were given a dose of atezolizumab, and after the initial 8 doses, they were they were primed. After the initial priming with 8 doses of this mRNA vaccine, they received 12 cycles of modified FOLFIRINOX, and then after that they got a booster dose. This is an upcoming technology of developing mRNA vaccines, and it did show that the disease-free survival was longer. So hopefully this is something which is upcoming. They have a phase 2 trial right now ongoing. We'll see more results about this trial. In terms of actionable mutations, as I was mentioning, there's 10% of the patients may have these mutations. We need to look for these because there are drugs available which can directly target these mutations. So we got to find these patients, because even if you benefit one patient who can receive these targeted therapies, they can have a tremendous impact. So in terms of, so there's a question here, if you have a patient with, I think we talked about this earlier, if they have a borderline PDAC and they have a BRCA mutation, what would be the neoadjuvant treatment regimen you would choose? So any platinum-based regimen, so modified FOLFIRINOX or GemCis should be given. This was one of the studies in which basically it was a retrospective study. Patients' data was analyzed, and patients who were basically matched with the therapy, like if they have a BRCA mutation and they received a platinum drug, they noted that in patients who were matched based into the therapy based on their mutational status, they had a better overall survival as compared to those who were not matched. Again, stressing the point, doing the somatic and genetic testing is important. MSI high, it accounts for less than 1% of the PDAC. This basically Keynote 016 showed that all patients who received were MSI high and they received immunotherapy, they responded. So even though this represents a minority of the patients, we should look for these patients. Again, BRCA1, BRCA2. So this is not just familial. Around 40% of the patients who have germline BRCA mutation, they have basically no family history of pancreatic cancer. So stressing again on the point of getting a germline testing done in these patients. There are other mutations which are also similar to DNA, similar to BRCA mutations. There's a list of these mutations. And again, we should look for these mutations. So we know basically based on this trial, GemCis was approved in patients who have platinum disease, in patients who have BRCA mutations. Again, platinum, they are sensitive to platinum. So giving GemCis or modified FOLFIRINOX is the go-to regimen for those patients. So this trial basically showed that patients who have HR deficiency, platinum, if we give them a platinum-based drug, they have better overall survival, they have high progression-free survival. I'm gonna skip this slide. So POLO trial was basically done in patients, again, who have these mutations. They were randomized, they got 16 weeks of chemo, and after that, if they had stable disease, they were put on maintenance olaparib. Final overall survival was not statistically different, but their progression, final overall survival was not statistically significant, but overall, I think, excuse me, if we are choosing patients based on carefully selecting these patients, I think there is a group of patients who benefit from olaparib. So again, this trial is for this cartoon basically mentions patients with HRD and what are the various treatment options which are available. For the other therapeutic targets like NTRK, BRAF, RET, KRAS, G12C, NRG. There are various targeted therapies which are approved. So the key is basically finding these patients. Again, I cannot stress on these. If there's a patient who has a diagnosis, please offer them genetic testing as well as somatic tumor profiling. And it can be done, the somatic tumor profiling can be done with a liquid biopsy or based on the tumor tissue. And this was a study which noted showed if there is a significant concordance of various genes which can be picked up both by liquid and tumor biopsy. So if you have a locally advanced disease, which is unresectable, and you're not able to get the tissue because of technical difficulties, or there's not enough tissue by an FNB from an FNA sample, so please send a liquid biopsy. The concordance rates are pretty high. And this is a therapeutic landscape for pancreatic ductal adenocarcinoma. We have come a long way, but a lot more needs to be done given the aggressive nature of this disease and the increasing incidence. So take-home points, triplet is better than a doublet. Please do the testing and germline as well as somatic testing. KRAS inhibitors are upcoming, and microsomal RNA is probably we're gonna hear more from that trial, and TIL therapy is something else which is also upcoming. I apologize, I might have run out of time, or I was going a little fast on my slides. Happy to answer any questions.
Thank you so much, Dr. Rahman, for really a tour de force of pancreatic cancer updates. That was a fantastic talk, and just really appreciate you providing such a high quality content. It was great. We're going to need to move on to our next speaker. And I just put in a link into the chat for all of our participants to please fill out for Dr. Rama, just an evaluation of her talk. Dr. Rahman, I've already sent you an eval for peer review. So I appreciate you doing this.
Thank you so much.
Wonderful job. Yeah.
Thanks so much. I have left my email ID in the chat if anyone has any questions. I do have to run to clinic, so I won't be here for any questions. But if you have any questions, please send me an email. I'll be happy to answer them.
Excellent. Thanks again.
Thank you.
So we'll move on to our next speaker. This is Dr. Kenneth Pitter, who's an assistant professor, radiation oncologist at Ohio State University. Dr. Pitter manages patients with gastrointestinal cancers, including esophageal cancer, pancreatic cancer, colorectal cancer, and hepatocellular carcinoma. Again, he's going to review the radiotherapy in gastric cancer. And I will pass this on to Dr. Pitter. He is going to be giving his talk from that should end around 3:40 time, or 8:40. You again can put in questions into the chat, and if he finishes at the end, we can take some questions as well. So Dr. Pitter, thank you so much for coming today. You can share your screens and get started.
Great, thank you. Let's see. Are you able to see the slides okay?
Yes.
All right, great. So good morning, everyone. My name is Dr. Ken Pitter. I am assistant professor here at Ohio State. I do laboratory research based on radiation resistance and GI malignancies, focused a little bit more on pancreas cancer at the moment, but clinically take care of patients with all GI cancers. I have no financial disclosures, and nothing that we talk about today is going to be off-label or non-FDA approved treatments. And so just quick background, we're going to be talking about gastric cancer, a very brief background with a little bit of a dive into anatomy to set up how we think about treatment paradigms, and then where radiation may have a role. And so globally, gastric cancer is still a major presence. It was formerly the #1 cancer in the world, but that has been displaced by lung cancer. The incidence in many parts of the world is decreasing, and this is in part because of the link between the H. pylori infection and as a risk factor for gastric cancer, and the success in recognizing and treating that. And so we talk about the risk factors. It does often present at an advanced disease, either stage 2 or higher, which leads to some of the challenges. So still a very high important cancer from a global tumor standpoint. Thankfully, it is decreasing, but still something that we do have to manage. In terms of anatomy, the stomach starts at the end of the GE junction, usually 40 to 45 centimeters from the incisors, and ends at the pylorus. It has 3 main parts: the fundus, the cardia, the body, and the antrum or pylorus. And I do want to point out that there is an overlap here, which I'm sure many of us are aware of. Is we use the Sievert classification as well for tumors of the gastroesophageal junction specifically. And so type 1 Sievert tumors are centered entirely in the distal esophagus. Type 2 are right at the junction, or what we call the Z line. And type 3 are truly in the stomach itself. And this classification can be tricky. This is from the AGCC. You have to kind of determine where is the tumor epicenter and what it is involving. And so these are 2 examples. This would be a Sievert 2 tumor. This would be a Sievert 3, although there's overlapping areas of disease. And the reason this is important is, at least currently in the United States and many parts of the world, Sievert 2 tumors can be managed either as gastric cancer or esophageal cancer. Sievert 1 are treated more as esophageal cancer, and Sievert 3 most is kind of true gastric cancer. There is overlap of these sites, obviously, and there's overlap in management. Today, I'm going to be focused primarily on gastric cancer. And for the purpose of this talk, we're going to ignore some of the very recent data that's come out about esophageal cancer, but we can bring that up in the discussion if it becomes relevant. Another important part of the anatomy for gastric cancer is the blood vessels, because this helps define a lot of the lymph node stations that we are worried about oncologically. So the stomach is supplied by the celiac axis, which includes the left gastric artery. The common hepatic artery has 2 branches that involve the stomach: the right gastric and the gastroduodenal, which give blood supply to the greater curvature. And then the splenic artery also has a branch that supplies the left gastroploic and the short gastric, which supply the fundus and the greater curvature as well. And so the reason that these blood vessels are important is because they help us define, one, they're required to be identified surgically, but they also, from a radiation oncology standpoint, help us to think about where the lymph nodes might be. And lymph nodes are very important in gastric cancer. The presence and number of lymph nodes is one of the most important prognostic factors. The optimal extent of how many lymph nodes need to be removed and which stations need to be moved is something that is still actively discussed, and we'll go through that here in a second. But NCCN, the National Cancer Society here, and also the AJCC, they recommend at least 15 lymph nodes be assessed pathologically to be an adequate lymph node dissection. And so if we look at some of these lymph nodes again, we have kind of our perigastric and pericardial lymph nodes, the lymph nodes that are immediately adjacent to the stomach. These are considered N1 lymph nodes, and then you have your vasculature, lymph nodes, celiac, left gastric, splenic hilum, hepatoduodenal. Those are also lymph nodes. And so these stations are defined. The Japanese Research Society established kind of a uniform language for how we do talk about these lymph nodes. And what the lymph node dissection classification is. So the N1 lymph nodes include the perigastric along the lesser curvature and greater curvature. N2 is lesser gastric, comma hepatic, celiac artery, and splenic artery. And here these numbers are what are considered lymph node stations. And so a D0 lymph node dissection is less than all of the N1 nodes. A D1 includes the right and left cardiac lymph nodes along the lesser and greater curvature, and suprapyloric along the right gastric artery and infrapyloric artery. And a D2 is a larger resection, and that includes more nodes along the left gastric artery, common hepatic artery, celiac artery, splenic hilum. And so oops, sorry, I jumped backwards. There have been randomized trials looking at doing a D1 versus a D2 resection, and the results are mixed. Some larger trials have shown that in randomized trials that there's no survival benefit to a D2 dissection, but it does have an increased morbidity and mortality. And so this is still something that is kind of debated and is going to be institution or practice specific. This does become relevant for us as radiation oncologists in a little bit. So now that we've talked about the lymph nodes and the extent of lymph node dissection, let's start talking about general treatment paradigms. So we think of gastric cancer in terms of T stage and N stage. I did not include the staging for reference here. I apologize for that. But for early stage tumors, T1A or less, so very superficially invasive tumors, the standard of care is endoscopic resection, which is both diagnostic and therapeutic. And so we want an endomucosal resection. And then as tumors get more invasive, we're talking about bigger surgeries, either partial or total gastrectomy, just depending on extent of disease and location. And when we're talking about these larger surgeries, there's big picture two treatment paradigms. You could do surgery first and then figure out your adjuvant treatment based on your pathological findings, or you can commit to perioperative treatment. And I'm going to start initially with the surgery first arm, because as a radiation oncologist, this is where gastric cancer have hit the map for us. And so there was the SWOG intergroup trial 0116, which was published in the early 2000s, also called the McDonald trial. And this was a randomized trial of patients that had a margin negative surgery, and they were randomized to either observation after surgery or to chemotherapy and chemoradiation with bolus 5-FU leucovorin for 2 cycles, followed by chemoradiation with 5-FU, followed by bolus 5-FU again. And this trial did show a durable long-term, both overall survival and relapse-free survival benefit to the adjuvant therapy compared to observation alone. And so this established adjuvant chemoradiation, given in this kind of sandwich factor way of chemo, as a standard of care for gastric cancer. Now, this trial was not without criticism, and the biggest criticism has to do, again, with the lymph nodes. So this is language from the trial, from the initial report in 2001. Gastric resection with an extensive D2 lymph node dissection was recommended. However, since patients were usually identified postoperatively, we could not require specific surgical procedures. Of the patients, only 10% had undergone a formal D2 dissection. A D1 dissection was performed in 36% of patients, but most patients, more than half of patients, had undergone a D0 dissection. And so this put radiation on the map as a standard of care. And this was practiced for a period of time. But there were other treatment paradigms that were being developed kind of contemporarily. And I'm going to switch. We're going to come back to the radiation paradigm in 1 minute, but also around the same time, there was investigation about perioperative therapy. And one of the early trials that looked at this was called the MAGIC trial. This was published in 2006. This is a perioperative strategy. So this is randomizing patients before surgery. Patients with either stage 2 or stage 3 disease were randomized to surgery alone or ECF chemotherapy, which is defined on the next slide, followed by surgery, followed by additional ECF therapy. And so they got 3 cycles before and after. The E is epirubicin, C is cisplatin, and F is 5-FU. The surgery was about 3 to 6 weeks in between the cycles, and this was powered to look at overall survival. This was a difficult treatment, and this is kind of a theme for gastric cancer, is it's a difficult cancer to treat. Clinically, the patients get sick. So more than half of patients did not complete all of their 6 cycles. However, even with only 40% of patients getting all the chemotherapy that was intended, there was a local recurrence benefit in favor of adding chemotherapy. There was a distant metastatic free benefit in terms of adding chemotherapy, and that not surprisingly resulted in both progression-free survival and overall survival advantages. And so now we have 2 trials that demonstrate superiority compared to surgery alone. We have the McDonald intergroup trial, which established the benefit of adjuvant chemotherapy and chemoradiation. We have the MAGIC trial, which established the benefit of perioperative chemotherapy. And so one question that came of this is, can we combine these approaches? This was the Critics trial. This was published in Lancet Oncology in 2018. And it randomized patients to either a MAGIC-esque arm. So again, this is epirubicin, cisplatin, and here we've switched out the 5-FU for capecitabine. There was also the option to use oxaliplatin instead of cisplatin for patients with that couldn't tolerate cisplatin or had pre-existing kidney disease. Patients then received surgery, which mandated a D1 plus lymph node dissection. So these patients had to have at least 15 lymph nodes removed. And then they completed another 3 cycles of adjuvant perioperative chemotherapy versus the chemoradiation arm. These patients also got, it says ECF, I apologize, that should be ECC or EOC, randomized to, again, a D1 plus surgery, and then got adjuvant chemoradiation. And there's just some more details. So again, a D1 plus surgery, which is a minimum of 15 lymph nodes, and the post-operative treatment had to start within 4 to 12 weeks after surgery. And so this trial showed no difference between the 2 arms, at least on initial follow-up. Both overall survival and progression-free survival were identical. There was some suggestion that local regional control might be slightly better in the chemoradiation arm, but that did not translate to an overall survival benefit. And so based on this data, if you're using perioperative chemotherapy, most people would just use chemotherapy. There's not a routine role for adjuvant radiation. And then just for completeness sake, I don't go too much into the details of this trial, but there was an updated to the MAGIC regimen. So this is the FLOT4 regimen, which is 5-FU, leucovorin, oxaliplatin, and docetaxel. And there was a benefit to FLOT4. So FLOT4 is kind of right now the standard of care for gastric cancer if you're using perioperative management. Do I have that next? And if you're taking a perioperative approach, there's no benefit to adding chemoradiation, at least based on these randomized trials. So that's the perioperative approach. Let's go back to the surgery first approach, and we will reset with the intergroup trial, the McDonald trial. So this did establish adjuvant chemoradiation as a standard of care, but there was no there was a poor quality of lymph node dissection, which was a very controversial topic. And so there were updated trials to look at that and ask if chemoradiation really gives a benefit if you have a higher quality surgery. So the ARTIST trial, which was run out of Korea, this compared adjuvant chemotherapy to adjuvant chemoradiation after a D2 lymph node dissection. So patients were randomized to either adjuvant capecitabine cisplatin regimen or a sandwich capecitabine cisplatin cape-based chemoradiation, capecitabine cisplatin adjuvant treatment. And just, I don't want to go through all the patient characteristics, but I do want to point out that there was a small percentage of patients, about 10% of patients, that were node positive. Most of the patients were at least N1 positive, with about 30% being N2 or N3. And on the initial report of this is the initial short-term report, the primary endpoint was disease-free survival. This did not reach statistical significance, but it seemed to be favoring the chemotherapy chemoradiation combination. Excuse me. And if you look specifically in the node positive patients, which was an unplanned subset analysis, there was an initial disease-free survival benefit. If you look at the more mature overall survival benefits, this is a longer term follow-up. There was no statistical difference here, but you still do see this tail that is maybe favoring chemoradiation. For disease-free survival. For overall survival, there's no hint of a difference between these two groups. But there were some interesting, again, on unplanned subset analysis. If you look at the lymph node positive patients, there was suggestion that maybe adjuvant chemoradiation would help these patients. And so this also became a standard of care for a period of time where if patients had upfront surgery and were node positive, we were treating with adjuvant chemoradiation in combination with chemotherapy. But this led to another well-designed trial, the ARTIST-2 trial, where we focused specifically on that subset of patients. So this compared adjuvant chemotherapy with chemoradiation, specifically in node-positive patients after a D2 lymph node dissection. So these are now margin-negative D2 surgeries that had to be pathologically node positive. And these were patients randomized to the drug S1 alone, which is a similar drug to capecitabine. S1 combined with oxaliplatin, and that was for 8 cycles adjuvantly, or they got S1-based chemoradiation followed by additional adjuvant SOCs. And this was powered for disease-free survival, and there was no benefit here. So the blue line at the bottom is S1 alone. Combining chemotherapy with multi-agent chemotherapy, S1 plus oxaliplatin improved 3-year disease-free survival, but the addition of radiation added no additional benefit. And so if we think about the conclusions for the surgery first approach, we have a nice series of trials here. The SWOG intergroup, where you had poor quality lymph node dissections, where chemoradiation did help. And then you had 2 ARTIST trials, the first suggesting maybe a benefit in lymph node positive patients, but then ARTIST-2, where you specifically looked at lymph node positive patients, showed no benefit to adding chemoradiation. Additionally, we had the perioperative approach, with the critics trial specifically, where it looked at combining neoadjuvant chemotherapy with post-operative chemoradiation, and there was no benefit there compared to peri-operative chemotherapy alone. So if we're doing surgery first, we know at this point there's no benefit of adjuvant chemoradiation over chemotherapy. The key point here is if there's an adequate lymph node dissection, we can consider adjuvant chemoradiation if it was a non-oncologic surgery or if an inadequate lymph node dissection. For perioperative treatment, there's no benefit of adding adjuvant chemoradiation to perioperative treatment as per the critics trial. And I do want to point out that the critics trial did not mandate a D2 dissection. So those patients, mostly 90% of them had D1 dissections with 15 lymph nodes removed. And so adequate lymph node dissection is kind of a more nuanced conversation for you to have with your multidisciplinary team. But based on these trials, there's no routine role for radiation in the treatment of gastric cancer, which is a big change over the last 20-25 years. That doesn't mean that there's no role for radiation. There is an open question about D1 versus D2 and how do you define what an adequate lymph node dissection is. What do we do with patients that have a positive margin is an interesting question. Another unanswered question is if patients have induction ECF or FLOT, what do we do if there's a poor pathologic response or if the tumor is not responding well? Are those patients that might benefit from adjuvant chemoradiation? And what about patients who are non-operative candidates? Is there a benefit to radiation there for local control? And these are all, I wouldn't say data-free questions, but we don't have randomized trials to address these. And so this is where best clinical judgment comes in. For our personal practice here, or my practice at Ohio State, we're not routinely doing, our surgeons don't do full D2 dissections. But if they felt the lymph node dissection was adequate, and if there was more than 15 lymph nodes removed, we're generally not offering adjuvant chemoradiation. The question of a positive margin is interesting. In most oncologic practices, adding in the presence of a positive margin would be an indication for at least adjuvant radiation, if not potentially a second surgery. But these are very large surgeries where additional surgery is often not feasible. We can talk about this more in the discussion, but some of the recent gastric cancer, or sorry, esophageal cancer literature looking at whether or not radiation has a role compared to perioperative chemotherapy, the rates of positive margins are higher in perioperative chemotherapy, but that hasn't so far translated to any differences in local recurrence or local regional recurrence, which is hard to understand why that is. But we will discuss with patients adjuvant chemoradiation for a positive margin. We would typically do that after completion of their perioperative chemotherapy or their adjuvant chemotherapy. For a poor response to neoadjuvant chemotherapy, if it's a perioperative approach, we're not routinely offering chemoradiation, although these patients often come up at multidisciplinary tumor boards, and depending on the patient and on the specific concerns, we will sometimes do this. And then non-operative candidates as well. There is controversy in the field whether there's any benefit to chemoradiation. The likelihood of chemoradiation being a curative approach in gastric cancer is very low. We know from some series by the RTOG and by MD Anderson that preoperative chemoradiation for gastric cancer has a pathologic complete response rate of around 20%. But how that translates to a durable non-operative approach is unclear. So if we have a patient who's not an operative candidate, we will discuss chemoradiation, but it's not an absolute reason. So hopefully the picture I've painted is that in your standard of care practice, we're not routinely doing radiation for gastric cancer anymore, but there are nuances in our times when we consider doing it. And so let's talk about the practicalities of if and when we're going to do it. And so the gastric post-op treatment is still defined by the SWOG trial. There is a seminal paper from Drs. Tepper and Gunderson. The PubMed ID is listed here. I'm also happy to put the link to the reference in the chat. And this defines kind of the treatment boundaries, which we'll go through some of those in a minute. And then in the more modern 3D era, there is this gastric lymph node contouring atlas, which is very helpful. Again, here's the PubMed link. I'm also happy to post the link to this in the chat as well. Just in general, for your radiation contouring questions, there's this really wonderful site called econtour.org. It's free to register for. It has a number of example cases on contouring. For gastric cancer, because of the progression of the trials that we went through, we're not routinely offering post-op radiation for gastric cancer. They don't have any examples of post-op gastric cancer treatment. They do have an intact gastric cancer, and there are ongoing trials currently to look at the role of preoperative radiation for gastric cancer, although many of those are combined GE junctional tumors, and some of those have been published recently, which we can again talk about in the discussion. But I was trying to focus today purely on the gastric part of gastric cancer. So if we are going to do treatment, the first part of treatment would be simulation. And so we recommend that these patients are fasted prior to their treatment or their planning scan, and also during treatment to keep the stomach position reproducible. We would do supine with IV contrast. I don't routinely give oral contrast for these patients because I think it distorts the anatomy, but you can use maybe a swallow of oral contrast to define the stomach or remnant. Arms overhead in the mobilization of your institution's choice. I say consider 4D scan. We do it if you have the opportunity to use a 4D scan. I think it's helpful here. And then our default treatment radiation modality is 3D conformal radiation, although we will use IMRT if we're unable to meet constraints. So this is the Tepper and Gunderson atlas for post-op treatment, where it goes through based on tumor location. This is reviewing pathologic data. What is the likelihood that these lymph node stations are involved, and therefore, what is the, how extensive do you need to be in your coverage? And so when we are doing this, it's very important to work closely with your surgeons and with your radiologists. The operative report, path report, and the preoperative imaging are really important for determining your post-treatment volumes, because there is a lot of, either depending on the surgery, if it's a partial or total gastrectomy, either way, the anatomy is often very different after treatment. And so we definitely want to cover our clinical tumor volume of our gastric remnant and adjacent remaining perigastric nodal tissue. We want to cover any anastomoses. We want to cover the celiac axis and also the splenic and pancreaduodenal suprapancreatic nodal beds, the porta hepatis, and the upper para-aortics, typically to L3. And then there's also some additional considerations depending on the location of the tumor. So for proximal tumors, you want to cover the lower paraesophageal nodal region, typically to T9. If there was extension through the wall for T4, T3 lesions, you're concerned for spread along the diaphragm. And so you want to cover that area. If we have the cardia or GE junction, again, we're talking about some more mediastinal lymph nodes in the periesophagus. And for distal lesions near the gastroduodenal junction, you want a 5 centimeter margin on the duodenal stump, especially depending on the pathology report. And for PTV, we typically do a 5 centimeter, sorry, a 5 millimeter expansion, and we are often doing these with daily cone beam imaging, although that's not always feasible given the resources at different institutions. So I'd say at least weekly cone beam imaging and daily orthogs. This is the gastric lymph node contouring atlas, which is, again, this is just a really helpful step-by-step, walks you through all the different relevant potential lymph node basins, where they are, what their boundaries are, and how you would cover them, with some examples of this is after a Ivor Lewis surgery, so an upper surgery. Will be after a Roux-en Y, and this is a subtotal gastrectomy. And so I don't think it's a great use of everyone's time to go through these one by one, but the atlas is there, and it's very helpful for when you have to do that. I'm going to skip this slide. These are our institutional treatment constraints. And so the lungs are often involved. Obviously, there's a lot of bowel. The heart can be involved. Kidneys we want to spare, in the liver as well. And so if we can't meet any of these constraints using 3D conformal radiation, we would switch to IMRT. And then in summary, so initially there was a role for adjuvant chemoradiation as a standard of care for gastric cancer, but that has been replaced either by perioperative chemotherapy or by adjuvant chemotherapy alone. There are some possible exceptions to this. If you're unable to perform an adequate lymph node resection, as determined by your tumor board or your surgeons, if you have an R1 resection, or if a patient has unresectable disease. There are some other open questions that we talked about. Particularly what if patients are unable to tolerate multi-agent chemotherapy? If someone can only get capecitabine alone or S1 alone, is there a role there? We're not sure. So we don't do this as much as we used to, but if we do, we typically use a combined chemotherapy sandwich approach similar to the intergroup SWOG trial. We would do 2 to 3 cycles of chemotherapy, followed by chemoradiation, followed by additional 2 to 3 cycles of chemotherapy. And we would use 45 gray and 25 fractions. We typically perform a 4D CT to account for movement, and we use 3D conformal radiation unless we can't meet constraints. That is the end of my update. We do have a couple of minutes for questions if there are any. And my email is here. I'll throw that in the chat as well. Thank you very much.
Thanks very much, Dr. Pitter. Appreciate that outstanding overview on the role of radiation in gastric cancer. We do have a question in the chat. How do we proceed for those upfront unresectable LA gastric cancer? Any role for preoperative CRT here?
Yeah, it's a great question, and there are a couple of trials looking at preoperative radiation. Those patients don't exactly fit that criteria of upfront unresectable. I can tell you what our institutional practice is. We would typically start those patients on chemotherapy, and reassess, see how they're doing. If you take care of these patients, you know that they are often very sick. They don't often do well with treatment. They're very hard to manage. They can spend a lot of time in the hospital, lots of nausea and vomiting. But I'd say our approach here would start them on multi-agent chemotherapy. We do try to use FLOT, but if someone has a very advanced cancer, they may only be a candidate for something like FOLFOX. And depending on how they're doing, we decide if they want to be fully locally aggressive, then we would treat with preoperative / definitive chemoradiation. We don't think that takes surgery off the table, but in my experience, the number of patients we're able to successfully convert to resectable is pretty small. Unfortunately, if they're locally advanced, either because of tumor response or because of patient performance status, it gets very difficult to get them to surgery.
Excellent. If there are any other questions, you can raise your hand or enter them into the chat. We will be also entering into the chat a link for each of you attendees to complete for Dr. Pitter's evaluation. This is very helpful for us, for our lecturers, but also for our future content, because we're doing this each year now. If there are no other questions, let's see. Yeah, Dr. Pitter just put his email in the chat as well. Looks like we do have a Q&A here. This is from Munir Aman. How do you see 3D CRT for post-op cases instead of IMRT/VMAT on current standards? Due to onboard imaging issues, we do 3D RCT mainly. So you see that question, Dr. Pitter, right?
Yeah, sorry. Yeah, there's some radiation speaking there. Yeah, so one of the benefits of a 3D conformal plan, which is what we normally try to do, is that they are a little bit more robust in terms of differences in where the bowel and the anatomy are on a daily basis. And so that it is our standard to do 3D conformal. Also, because of onboard imaging issues, if you have to do a cone beam every day, that slows down treatment time and it increases your physician demand in terms of having to review that every day. So 3D conformal is perfectly acceptable, and that's what we do unless we can't meet specific constraints. And I agree with that approach. There were a couple of other questions that jumped in the chat, and we have 2 minutes, so I will run through them quickly. So one is, do we do a laparoscopy before definitive chemoradiation? So we try to do laparoscopies before committing to any definitive treatment, whether perioperative chemo or surgery up front. Yes, because we do want to rule out occult peritoneal spread. And so our surgeons are on board with that approach. And then a place for neoadjuvant immunotherapy for MSI-high gastric cancers, a very interesting topic, one I didn't talk about at all. I'm going to switch to a different GI site, which is rectal cancer. There's very exciting data for rectal cancer for patients that are MSI high, where a large percentage, the published series is 100%. Real world data maybe isn't quite that high, but at least a significant portion of patients have a complete response to immunotherapy alone, meaning they don't need any chemotherapy, any radiation, or any surgery. Now that's in rectal cancer. We don't have data to support that approach in gastric cancer yet, but that would be, I would not feel comfortable treating patients like that off a clinical trial. But that's certainly a very exciting question is for MSI high gastric patients, what's the role of immunotherapy? Because again, the surgery and other treatments are pretty morbid. So it would be a very exciting space.
That's super interesting. Let me follow with a question. Are those rectal cancers that are MSI high, are they also HPV positive majority or negative?
Those are majority negative. So the data for immunotherapy in anal cancer, where it's more of a squamous HPV positive, there is a signal there as well, but it is not as high as the MSI high patients. We're not as strong, I should say.
That's very interesting. I'll have to look at that. Thank you. Well, great, Dr. Pitter, thank you so much. It was a great lecture and appreciate all the questions at the end. There's a link now in the chat for our attendees to complete for Dr. Pitter. And we'll move on to our next speaker now. So thank you. Our next speaker is here. This is Lingbing Meng. She's an MD PhD, member of our faculty in the Division of Medical Oncology. She's an assistant professor, and she specializes in treating malignancies affecting the reproductive and urinary system, so GU, including prostate, bladder, kidney, and testicular cancer. Her topic of her talk today is on the management of early stage prostate cancer. And please enter your questions into the chat during her talk, and at the end we can take some questions like we just did, and we'll also be putting a link in to the chat for her evaluation as well. So thank you, Dr. Meng, for being here today. Really appreciate it, and you can get started.
Sure, my pleasure. Thank you. I will take care of this share screen. Okay. Okay. Could everyone see my screen?
Yes.
Perfect. Thank you. Good morning, everyone. Yeah, this is Lin Bian. I graduated from Moffitt last year and joined OSU since last summer as a GU med onc physician. So today I'm going to talk about the early stage prostate cancer. Okay.
Dr. Meng, could you switch it to the presentation mode?
Sure. Let me see.
In the bottom right of the PowerPoint.
Okay. Exciting. It is mode correct now?
No, it's still just showing the other view, but
Oh.
it's okay. You can get started.
Maybe let's see. Give me 1 second. I have to create another. Can I just start over?
Yeah.
Okay. Yeah, because I have a double screen, so I think probably you didn't choose the right one. Let me stop sharing. It is working now?
Yes,
Perfect.
thank you. We're
Great,
recording, so I
great.
just want to make sure we have it the best we can. So
Definitely.
thanks.
Sure, my pleasure. Well, so this is as we mentioned before, we are going to talk about early stage prostate cancer, and this is the outline that we are going to talk about today. We are going to briefly talk about the genetics, the risk factor, epidemiology, prevention, yes, screening, and how we diagnose and treat early stage prostate cancer. And last but not least, we're going to briefly talk about the biochemical recurrency and salvage therapy. First of all, so as we know, the prostate cancer is the most common cancer in the men in the US, and it is the second leading cause of the cancer deaths in American men. The overall survival of the prostate cancer, generally speaking, is good. From 2013 to 2019, the 5-year survival is about 97%. And among all those patients, 70% patients was diagnosed as a localized disease, while only 80% of patients diagnosed as distant metastasis at the initial visits. Regarding the survival, if patients have a localized disease, the 5-year survival is about 100%. However, when the disease travels to the distant, only 34%. So early detection is always very important. There are several risk factors contribute to prostate cancer, including age, family history, race, genetic, diet, chemical exposure, and etc. So So we're going to emphasize on genetic today. As we know, the high-risk inherited genetic factor could occur in 5 to 10% of prostate cancer. And for the patients have the familial prostate cancer gene, that can increase the risk to 2 to 3 folds, which includes HOXB13, MMR, BRCA, and DNA repair gene mutation. So when should we do genetic test? This is a guideline from the NCCN. Generally speaking, they recommended all the patients who have been diagnosed with a metastatic stage, or if the early onset, which means less than 50 years old, or other a strong family history, like multiple family member with the cancer. So then we will indicate the patient to get a genetic test. So when should we do the somatic tumor testing? Again, on the guideline, so far we recommended patients to get the somatic tumor testing if they have a metastatic disease. Especially we recommended to test the homologous recombination DNA repair gene, such as BRCA, ATM, etc. And also the TMB and the DMMR will be important for the indication whether we need immunotherapy. So prevention. Is there any way we can prevent prostate cancer? The answer is not sure. This is a study, they try to evaluate whether the vitamin supplements that can prevent the prostate cancer, and the result is negative. There are two trials, PCPT trial and the reduced trial, try to investigate whether 5-alpha reductase inhibitor could prevent prostate cancer. This is the PCPT trial. They give all the patients finasteride and vs placebo if patient above 55 years old, while the PSA less than 3. And this result, basically there's no difference in the overall survival at 15 years follow-up, and no difference in the incidence at 18 years follow-up. And besides that, they even find finasteride group had increased the risk of a high-grade cancer. However, the reduced trial shows some controversial finding. They gave dutasteride for the patients who has the PSA between 2.5 to 10, and after several years, they follow the incidence of prostate cancer. They do find for the patient received dutasteride decreased the risk of prostate cancer. So due to this controversial, so far, I would say there's no proved preventive agents for the prostate cancer. In the future, that could be involved more research project to figure out there any new novel treatment. For example, from the last year ASCO, they has been testing some like animal acid, some like a protein expression, but so far it's still premature. So we can keep following that. For the PSA screening, in the past, from before 2012, the US PSTF doesn't recommend prostate cancer screening by testing PSA because it leads to false positive result, and more patients have anxiety and increased their cost. However, after they discontinue that, they find even the incidence of localized prostate cancer decreased since 2012, but the rate of metastatic prostate cancer has been rising. So that is why from 2018, now they will recommend screening from individuals, which means those patients have the high risk feature. So this is the most top 3 popular trial to investigate the PSA screening, which is the PLCO trial and the ESRPC trial and the Goldberg trial. Again, the result was controversial. For the PLCO cancer screening trial, it was a negative. They find by screening the PSA does not decrease the prostate cancer incidence. However, for the second trial, they find by testing the PSA, the incidence of prostate cancer decreased and a decrease in mortality. So due to this conflicting results between the two trials, so far it's still controversial. I would say this between patients and physicians' preference and comfortable level. I would still recommend to do that if the patient have the strong family history or increased, for example, the PSA increased more than 4, and suddenly I would still definitely repeat. For example, if the patient has the PSA is between 4 to 9.9, usually we will repeat the PSA in the next 6 weeks. And if there's a persistent high, I would refer to the urology, either for the DRE or the biopsy. If the patient has been on the 5-alpha reductase inhibitor for the BPH, usually in the clinical practice, I would double his PSA. And besides, during the visit, if you find any abnormal finding from the DRE examination, for example, any nodular induration, pre-shape, I would say it is very important to refer them to the urology for further workup. Okay, so how do we diagnose this prostate cancer and staging them? As we mentioned before, the biopsy, the PSA value, and the staging scans is very important. So this is how we stage prostate cancer. I'm not going to tell too much detail. Basically, if patient was incidentally found has a PSA increase, that will be T1C. And if it's only localized within the prostate, if it's less than 1/2 of the lobe, that will be 2A. If it's more than half of the one lobe, that will be 2B. One thing need to mention, if the patient's tumor invaded with actual capsular, that will be T3B. It is involved with the seminal vesicle, that will be 3B. So that will be very important when we're staging, because if they meet that criteria, patient will be automatically to the high-risk group. When we're staging, it's important to get the Gleason score, because that will be very helpful to tell us how aggressive the disease is. This is how we stage, as we mentioned, the TNM, PSA value, and the grade group. And the grade group is based on the Gleason score on the pathology report. This stability slide is very important. As we mentioned before, when the patient have the clinical T3A or T3B, that will be automatically grouped to the high risk group or very high risk group, no matter the PSA value. So this is very important in the real practice. So when should we open scan? Generally speaking, if a patient above or equal to unfavorable intermediate risk, the scan for staging is warranted. We can either do the conventional scan, which is the bone scan and the CT scan, and you can also do the MRI prostate. That would be very good for the local anatomy. Recently, the PSMA pad is very popular because it's a high sensitivity. As we mentioned, if the PSA above 2, the sensitivity could up to 97%. That is why from the ASCO PC image guideline in 2020, the PSMA pad is recommended for the patient have the equivocal finding from the conventional scan. And due to this high sensitivity, recently they even be approved as a frontline staging scan, which means we can just do the PSMA pad for the patients equals or above to unfavorable intermediate risk if you doesn't like a conventional scan. Or if a patient have like a kidney failure, cannot tolerate the contrast with the CT, and then PSMA pad will be a good option. How we treat them? This is the general picture, the flow of the natural history of the prostate cancer. We are going to focus on the early stage today, and Dr. Folefak going to talk about more for the advanced stage tomorrow. Okay. For the localized disease, as we mentioned before, we treat it based on the risk of stratification. Generally speaking, there are several approaches. We can either choose active surveillance, surgery, or radiation. For the very low risk or low risk disease, there are several options. You can either do the radiation or surveillance or surgery, but which one is better? So here's a trial, PROTECT-T trial, which is a very important study. They compared patients between the active surveillance, prostatectomy, and the radiation therapy for patients with very low or low risk group. And interesting, the study found it doesn't change too much regarding the overall survival and the cancer-related survival. So the study showed there's no significant difference in the cancer-specific survival between the three groups. That is why currently we are still more favored active monitor for the patient have the very low and the low risk group. One thing to mention from the last Alliance meeting in 2024, there's some ongoing study trying to see whether metformin could be used as the guider, or I would say predictive role to see whether patient would benefit from the active surveillance or definitely treatment. But that studies are still ongoing. We will keep an eye on it. For the patient choose active surveillance, it doesn't mean nothing. It still should do the PSA, the DRE or biopsy as needed. It's based on the annual MI or like DRE examination. Or if a patient have a sudden PSA increase, that warrants earlier follow-up with biopsy. For the patient with the intermediate risk, you can either do the radiation or surgery. Here, we're going to talk about the EOC trial and the RTOG trial. These two trials focused on to answer two questions. One is whether benefits by adding ADT to radiation. The second question is, what's the best duration of ADT treatment? So first, the EOT trial, they try to investigate whether RT with or without hormone therapy will benefit for the patient with intermediate risk. And the answer is yes. Concurrent radiation with the chemo shows better survival compared to radiation alone. The 10 years overall survival was favored by adding the ADT. Besides, the RTOG trial tried to investigate whether all the patient all the patients with the intermediate risk group benefits from the adding ADT. So they subgroup the patients to favorable intermediate risk and unfavorable intermediate risk. The result is surprising. For the patients with unfavorable intermediate risk, they benefit more by adding ADT. Why? For the patients only have favorable intermediate risk group, they didn't benefit by adding ADT. That is why currently on the guideline for the favorable intermediate risk, we would recommend radiation alone. Why for unfavorable group, we would recommend adding hormone therapy for 4 to 6 months. So this is the summary of how we treat intermediate risk. I will list there for your reference. High risk. Well, similarly, you can either do surgery or radiation. For the radiation, we recommend adding ADT based on this 3 large trial. The data demonstrate by adding ADT, it significantly improved overall survival. But then the next question comes, what is the best duration of ADT with the primary RT? Based on this 3 trial, it shows, well, the longer is better, but 18 months is not inferior compared to 36 months. So that is why on the guideline, they would recommend the ADT from 1 to 3 years on top of radiation. So recently, based on the STEMP trial, they addressed another issue. For the patient with very high risk, should we intensify the treatment? And the answer is yes. In the STEMP trial, they enrolled all the patients with very high risk non-metastatic prostate cancer. And if a patient meets 2 of the 3 criteria, which is T3, T4 stage, grade group 4 to 5, or PSA above 40, they do find the patient by adding the abiraterone for 2 years, patient's 3-year free survival was 75 compared to 45%. So that is why they recommended adding the abiraterone to the ADT for those patients. That is why on the guideline is updated here. For patients with very high risk who meet the 2 of 3 criteria, we recommend the radiation plus ADT 2 years and abiraterone for 2 years. Okay. So here is a summary of how we treat high risk or very high risk group. For the high risk group, when we recommended concurrent hormone therapy, we would recommend it 18 to 36 months. For the patients with very high risk, we would recommend 18 to 36 months ADT, but if patient meet 2 of 3 criteria, they may benefit by adding the abiraterone as well. Here's some biomarker I want to briefly introduce here. For example, the Decipher. It has been investigated that the Decipher can play a prognosis role to tell us how, like predict the patients have the development of metastatic disease post-prostatectomy. So currently there are several trials, RTOG trial, try to use the Decipher as a predict, I would say as the biomarker to let us know whether we can intensify the treatment or de-intensify treatment. This is RTOG trial for the unfavorable intermediate group, and this is a trial for the high-risk prostate group. This data is still ongoing, and hope by next year we will have some preliminary data. On top of that, artificial intelligence is also a potential useful marker to play both prognosis role and predictive role in treatment of early stage prostate cancer. At ASCO last year, it has been shown they have established the model to tell for the patients who has the AR positive marker benefits more by adding hormone therapy. So this is data to be reviewed next year. Okay. So then we will talk about more about regional node disease shortly. So for the patient who have clinical lymph node involvement, they usually classified as a stage 4 disease. When we say stage 4, if the patient have no distant metastasis, we will still give the definite therapy by radiate the lymph node or surgical resection. So that is different from other stage 4 disease of like lung cancer or GI cancer. Generally speaking, for the patient with local advanced lymph node involved, the prognosis is still good. As we mentioned, there are 2 ways to treat. One is prostatectomy, and the second is radiation. By adding to the ADT to the radiation, we also recommended abiraterone for 24 months based on the STAMPEDE trial, because it shows its benefits by improving the local control and decrease the distant metastasis. But one thing to mention, the study has been showing the abiraterone is not so friendly to the elderly patient because it's the cardiovascular toxicity and usually can cause low potassium, the liver function compromise. So it still need to like cooperate into patients' other comorbidities when you make the decision. Okay. Salvage therapy is also important, so let's talk about more about that. What is the salvage therapy? So before that, I want to briefly talk about biochemical recurrency. Generally, after the definite therapy, we would continue following the PSA. For the patient who had radiation, if the PSA above 2 of the nadir level or jumped quickly or close to 2, we can call it biochemical recurrency if the image didn't show recurrent of the disease. If the patient have the prostatectomy at the beginning, and then the PSA consistently increase more than 0.1 to 0.2, and that will be termed as biochemical recurrency. It's very important to do the staging scan when you find the patient's PSA increased after definite therapy, because we want to rule out the possibility of metastasis. So PSMA PET will be good to tell distant metastasis, and prostate MI will be important to tell the local anatomy environment. And biopsy is warranted sometimes. What is a local salvage therapy option for the prostate cancer? You can either do the surveillance, you can either do the palliative ADT if a patient cannot get any surgery or radiation. For the salvage local therapy, it includes brachy, radiation, cryotherapy, HIFU, or prostatectomy. So currently, I'm going to talk about the 2 important trials, which is GATUG trial and RTOG trial, to guide us how would we approach patients with rising PSA after prostatectomy. So this first study, RTOG trial, the enrolled patients who had the PSA increased after prostatectomy. For one group, they only have salvage radiation. Another group, they add bicalutamide for 24 months, and they found the 4% OS benefits for those patients. So demonstrate adding ADT to the salvage radiation could benefit patients more. And the second trial, the GATUG trial, this one, the one group patient received radiation, and another group, they add 6 months hormone therapy. And the results shows 10 years metastatic free survival is better by adding the hormone therapy. This trial, Radical HD trial, is very important because it's compared the duration of ADT to the salvage radiation. They randomized the patients to either radiation alone, radiation plus the 6 months chemotherapy, or radiation plus 2 years chemotherapy. And the data shows longer the better. The 24 months ADT has better metastatic-free survival. That is why this is a summary of this trial I just mentioned. This is why I want to say, even though it is controversial between physicians' preference how to cope with rising PSA post-prostatectomy, but we can follow this 3 trial. For example, if from the Radical RT trial, we demonstrate that if the patient have the rising PSA, we would recommend give the early salvage radiation other than adjuvant radiation. I didn't put too much data there just because the limit of the time. But in the past, when we treat with patients post-prostatectomy, but with positive margin, they has been given adjuvant radiation. However, for those patients, they have a lot of the consequential post-surgery and a lot of the complication post-radiation if you do it quickly. That is why even you do the adjuvant radiation, we would recommend wait until 6 to 12 months post-surgery. And now recently, based on the Radical trial, they find the adjuvant radiation's outcome is similar to early salvage radiation, which means we can wait until the PSA goes up, meet the criteria for the biochemical recurrency, and then you can keep the radiation. And that will not interfere patient's clinical outcome. And the second one, the RDOG trial and the GALUG trial just mentioned, for the patients who had a BCR, when we give us radiation plus the hormone therapy, that will be better than the radiation alone. And regarding the duration, based on the Radical HD trial, the longer duration of ADT is better than short-term ADT. If sometimes the physician will ask, I did the PET scan, but I didn't find any local recurrent disease in the prostate. Should I still give the early salvage therapy? I would say yes. Even it's negative, but it's based on the clinical trial, it still benefits by giving the early salvage radiation therapy. This trial, the Formula 509, I just want to some update about this trial because it has been hot 2 years ago. It is about the triplet therapy, which means on top of the ADT and RT, they give abiraterone and apalutamide. The data shows some like benefits of the clinical outcome regarding the MFS. However, it brings more toxic I would say the toxic panel was more prominent. That is why currently we are not really recommending this triplet therapy. It is like little overkill. Okay. So this is a summarize how we cope with the patient has rising PSA post-prostatectomy. You can just based on patient's preference, side effects panel, figures a comfortable level as well. If the patient have some high risks, for example, PSA was high or like histology high risk feature or high decipher score, usually we would recommend it's 2 years ADT instead of give RT radiation alone. Okay. Last but not least, for the patient have the BCR after definitive and salvage therapy, what should we do? There have been several questions ongoing with no clear answer. Those questions focus on whether we treat or not treat. When should we treat? What is the best duration of the treatment? And if we treat, should we give ADT continuously or intermittently or immediately? So before we talk about this, I want to briefly just catch up with the Gleason score and the PSA doubling time, because this is a good marker to tell us like how aggressive the disease. It can predict the patient's metastatic-free survival. This is a study published in 2004 and 2015. They compared the patients with early intervention of the hormone therapy vs delayed hormone therapy. And the result shows there's no difference. However, for the patients had high risk feature, which means Gleason score more than 7, they benefit by early hormone therapy in the biochemical recurrence setting. However, another paper published in the JCO in 2014, it shows no difference in the mortality regardless of early or delayed ADT therapy. And per the TOAD trial, it also shows some controversial finding. It shows by giving the hormone therapy, it can decrease it can if you give the hormone therapy immediately, it can increase patients' overall survival. So that is why this area has been controversial. And then how would we approach that? So for me, I would just focus on the patient's risk feature, which means if the patient have the high risk feature, for example, if the prostatectomy, if the patient's PSA doubling times less than 1 year, or Gleason score 8 to 10, I would prefer to treat them early. For the patients who had radiation before, and biochemical recurrence happens within 18 months, or the Gleason score between 8 to 10, we would say, oh, they have a high risk feature, we probably should treat them early, hormone, other than delay. So that is one way to approach. But generally speaking, this is no clear answer. Ideally, I would say I would try to keep the patient's PSA less than 5 to 10 if they meet the criteria for the high risk feature. So when we give the ADT, it is matter to give it continuously or intermittent. This study published in the NEJM in 2012, it demonstrates there's no difference regarding the median overall survival and no difference in the disease-specific survival. Okay. So last but not least, I'm going to emphasize this trial, NBAC trial. So this is a trial published in NEJM last year. It enrolled patients who had a biochemical recurrency with a PSA doubling time less than 9 months. All the patients were randomized to the ADT group, the enzalutamide group, or the combination group. And the result was interesting. By this result, we could find adding the enzalutamide to the ADT had better metastatic-free survival compared to ADT alone. And even if you focus on monotherapy of enzalutamide, it has a better MFS compared to ADT alone. And regarding the overall survival, the enzalutamide combination also better than the ADT alone. So that may change the way we practice. This is a secondary endpoint you can see from all the respective MS, OS, PSA progression. They all show benefits of enzalutamide monotherapy compared to lupron alone. So I would say, for me, in the practice, if patient meet this in this scenario, if they strongly doesn't like ADT induced hot flashing, the testosterone induced sexual desire decreased, or they already have the very bad osteopenia, osteoporosis, or cardiovascular disease, I would say monotherapy with the enzalutamide could be one of the options. So this is the group analysis to see how deep the PSA response between the three groups. And you would find the combination of enzalutamide plus the ADT has the deepest PSA response, which means 90% of patients had the PSA less than 0.2 after the treatment. However, for the lupron, which is ADT alone, only 6 to 7% of patients achieve that. The one thing you need to put attention, for the patient who has been on enzalutamide alone, they since has very quick withdrawal. So the suspension of the median duration of the suspension is the shortest among the three groups. And then they do further analysis, and they do find, even though those patients having on the enzalutamide has the withdrawal, which means the PSA coming back very soon after discontinued treatment, the survival is still good. It's better than ADT alone, no matter the on the treatment suspension or no treatment suspension. So I think this is a very positive study. It has significant clinical significance. It changes the way we practice. Regarding the side effects, enzalutamide doesn't bring, I would say it's very similar to the ADT in the short-term side effects, but it increases risks of gynecomastia. So that is very interesting. In the future, whether we can give tamoxifen or radiation for those patients with this issue is a question to be answered. So here's to summarize how we approach the BCR. Usually we do the staging. If they have a metastatic disease positive on the scan, we would usually give a continuous hormone therapy. If the patient has no disease coming back, but just a BCR, we would, depend on the IMbark trial, if the PSA doubling time less than 9 months, you can follow IMbark trial. If this doubling time more than 9 months, you can either monitor or do clinical trial. If the patient have oligometastasis, we can give ADT and definitive radiation for the oligometastatic site. Okay. Last but not least, one thing to mention, when the patient have the biochemical recurrency, it's always very important to make sure there's no metastatic disease. And if the patients have, we need to monitor the PSA by doubling time. If we started, if the PSA less than 10 months, doubling time less than 10 months, but still keeps in non-metastatic state. On top of the ADT, we should consider adding the apalutamide, darolutamide, or enzalutamide, even though there's a small population, but still should be bring to attention. Okay, so that is all my talk today. Any questions? Thank you for coming. I left my email address there. If you have any question, just be free to reach out to me.
Thank you very much, Dr. Meng. Appreciate you providing that outstanding lecture. We have a couple questions here in the Q&A.
Sure.
Let's see here. What are the possible surrogate endpoint biomarkers for severity or survival for performing joint modeling of time to event and longitudinal dynamics of biomarkers? You've covered that.
Let me see. Oh, I saw that. Oh, well, yeah, this is a biomarker. I would say that's a very, very good question. So far we don't have good biomarker. It has been some saying to use the circulating DNA. But as we mentioned in the early stage, the tumor shading is not a lot. So the sensitivity of a circulating DNA in the peripheral blood is warranted. There has been some study ongoing trying to investigate whether we can use a circulating DNA as biomarker. But I would say this data is more mature in the advanced metastatic setting. And besides, as we mentioned, Decipher could be an important biomarker, but so far it's only used as a prognosis role, not predictive role. And artificial intelligence could be used as both. But regarding the future, they definitely need more data. Where we don't have a mature data on that. For the next question, follow-up maturity, how many years do you suggest a follow-up time to be for preventing? That was interesting. So far, I would say, as long as the patient about 50 years old, we usually do the screening of the PSA. And after the treatment, we usually at least do a very frequent check PSA for within the first 5 years. And after that is annual check. So that is no certain answer. I would say it depends on patient's family history, risk factor, and also his comfortable level. But if he doesn't have any like strong genetic, positive genetic disease running in the family, no clinical symptom, I would say once per year since the patient about 50 years is reasonable to me. Yeah, did I answer the question?
I think so, yes. And there's another one in the Q&A here from Iraman. Can you see that?
Yes, I think I just I think I read the last one and answered the last question. That is the okay. So what is a possible surrogate endpoint?
Oh no. It's the next question. I think you already answered that one.
Oh, okay. So I saw the new one. Yes, the enzalutamide, right?
Yes.
Yes, this one I just see. Out of pocket, I'll say. So it's out of pocket, expensive. We have a lower dosing strategy in that room. Do you think kind of like enzalutamide? Yes, this is a great point. I also got the issue. So some patient complaints about this kind of expensive, depends on the different insurance pocket. I would say sometimes I have, but I haven't tried low dose because it's just newly approved. We didn't have so many patients put on this drug. But I think it is reasonable to start at like a low dose and see how is the PSA controlled. If this PSA controlled very well, I don't think that will be an issue. Like abiraterone, even though the standard treatment is 1,000 milligram with a low-fat male, but actually the outcome is similar to the 250 with, I put it otherwise. So in the standard way, the abiraterone should be 1,000 milligram with like a prednisone. But however, when found, if the patients only take 250, but with low-fat meal, the efficacy is very similar. So far, we don't have very solid study to compare this like co-response between these two drugs, where they have a similar mechanism with a low dose, but change of the diet could meet the same efficacy. But I think it is reasonable to start a low dose and the lutamide if patient cannot pay out of pocket and afford that, and see how is the PSA controlled. If it's PSA controlled well, I would think it is totally okay. Yeah.
And then there are several questions in the chat. The first one's place of chemotherapy, docetaxel for high and very high risk prostate cancer.
I saw that. Thank you. Oh, that's several questions here. Yeah, for the
Yes.
first question, great. So for the first question, that's a great point. So far, we are not strongly recommend that. But Dr. McKay from the UCSD, they're developing a trial to see whether we should add docetaxel for the patient have a very high risk with a biomarker of artificial intelligence. So that may be something changing in the future, but at this moment, we don't have the mature data on this. On the guideline, we not recommend it just because it's toxicity. And abiraterone works very well and better tolerant than the chemo. So we will use the abiraterone other than doxy more in this scenario. But in the future, whether based on the new model, we will intensify treatment with docetaxel. That is good question to be answered. Yeah. And the second, should I continue with the second question?
Yes, yes, sure.
Because I can read the question here.
Yeah.
How can we treat for those who had biochemical currency only after definitive radiation? And do we have to go to the salvage surgery or anything else? But yeah, this is also a good question. Sometimes when the patient have the definitive radiation and have the biochemical currency, we always refer them to the urology group for investigate candidacy for the surgery, see whether they can tolerate surgery. Sometimes urology will say, hey, we can give a try, can do cryo or HIFO. Sometimes they will say, that's tricky. And then we would ask them to follow with the radon, because if the patient have the definite radiation 5 years ago, and sometimes the radon can do the proton or like the brachy, they can still radiate the prostate. So that is the two options. We can still do the salvage therapy. Sometimes if patients not candidate for either of them, it depends on like how quickly its PSAs go up, right? And what is the Gleason score, whether he meets the high risk feature. If he doesn't have any of them, I'm okay with just observation. Yeah. The last question, the role of elective lymph node irradiation in a non-metastatic prostate carcinoma. So does it mean when the patient initially come here with, because it's not quite sure where's the location of the lymph node, right? So in our practice, if the lymph node truly light up on the PSMA PET, and highly suspect for the local environment, we will still do either radiation or surgical resection. Sometimes surgical resection will be hard because once involved with the lymph node, urology will be, free to do that because it's too, it's very challenging to get rid of all of them. But rad-onc doctor, from my experience, are all very confident to radiate this lymph node. It's closer to the prostate. So I would still refer those patients to the rad-onc for the evaluation.
Okay, excellent.
Thank
If
you.
there are no other questions, there will be a link placed in the chat for attendees to complete an evaluation of this outstanding talk and discussion from Dr. Meng. Dr. Meng, thank you so much for coming today and providing this great material. We appreciate that, and appreciate everyone showing up and giving great questions and participating today. Tomorrow, we will hear from 3 additional speakers that will be reviewing several topics that I can quickly show on the screen. See, where are we? Here we are. So tomorrow we will hear from Dr. Devarakonda, Dr. Sim, and Dr. Folefak on management of multiple myeloma, on approach for radiotherapy for heme malignancies, and for advances in urologic malignancies. That will be starting tomorrow morning at 2:05 Eastern African time, or 7:05 Eastern Standard Time. So again, thank you everyone, and Dr. Meng's evaluation link is now in the chat, so please do that, and please show up tomorrow morning for more outstanding material for hematology oncology for the Global One Health Summer Institute and the Ethiopian Society for Hematology and Oncology. So thanks again. Have a great day.
Thank you. Bye.
Bye.
Bye.